once or twice. Our advocates will often see these patients or maintain contact with these patients for months or even years and get them into additional services, counseling, support groups, additional sexuality information and care. So there's a variety of things that the advocates do while we're here in the emergency room. And I tell people all the time, advocates are not hand holders. Advocates are specially trained, highly trained in the variety of aspects of sexual assault. Not just what's going on and how they may be reacting and feeling initially and then immediately after, but how this impacts them not just emotionally, potentially for long term, but how this may affect them physically and their own sense of sexuality and self-identity. So one of the things that's most important is certainly to sell your services as an expert in the field. And not let somebody talk to you as if you're, a mere handholder sitting there patting a hand, saying, "It's okay, honey, you can get through this." We may be doing this to protect a case. We may be doing this to provide safety. The teenager may not have a safe place at home, and it may be the assailant is mom's boyfriend. What are we going to do to maintain the safety of that child? It also, with adults, increases the likelihood of reporting. If they come in and are seen, there is a very high likelihood that they will report right there in the emergency room, and certainly usually within 30 days if they have to think about it for a little bit. So there's a variety of reasons to do an assessment. I have 9-year-old boys that have come in and felt that they were pregnant. We do a pregnancy test and we assure them that they're not pregnant, and they're very happy, and we send them on the way. Teenagers especially may remember that as a child it hurt. Now they're entering a time period where they're exploring or at least thinking about sexuality, and they believe that anybody who has sex with them is going to know that they're sexually assaulted. They remember that it hurt, they remember that it possibly bled, and now they believe that there are terrible scars that people will recognize. So again, reassurance is also something that's very important in doing an assessment. When we look at barriers to providing care, a very common barrier is fear of how much it's going to cost. In the state of Washington, we've taken care of that. By law, we may charge the initial medical forensic evaluation, the initial one, so that's the one where they first come in. We may charge that only to the Crime Victims Compensation Fund. They cannot be denied. They do not have to report to law enforcement. They do not have to make a claim to crime victims. It's sent in with a special form. It's automatically paid. Following that, they may want or they may need follow-up care. So if they have an injury and they need to come in and get additional evaluations after the fact, that's considered follow-up care. And that does require a claim. That does require filing a report. It does require cooperating with the investigation. But the very initial exam, so if you're talking to somebody on the crisis line, you can assure them that they can come in and it will be taken care of, and they will not be charged in any way for that initial medical forensic evaluation. Having said that, crime victims will diagnose outside of the sexual assault arena, but they will not pay for treatment. So an example is she may have a broken arm. Crime victims will pay for the x-rays, but they will not pay for the splint or the sling. So those are treatments versus diagnosis. All of that would be covered under follow-up care. And again, they would have to file a claim and they would have to participate in an investigation. Okay? So let's talk about what the standard walkthrough in an emergency might look like. They're going to come in and identify to somebody based on each hospital's standard, how they do their triage or how they determine who gets seen when, but basically announce somehow that they've been sexually assaulted. And a triage nurse or somebody will initially talk to them. And the purpose of that is to determine, is this a life-threatening event or not? And this is an area that can be very frustrating for advocates, ERs will see patients based on the severity of their problem. They do not view sexual assault unless there are significant injuries as a high trauma-based condition. So it's not unusual that, especially if you don't have a team that's coming in, that they will sit and wait until everything that needs to have x-rays, that needs to have some sort of intervention or emergency medication. Certainly heart attacks, strokes, things like that are always going to come first. But sick babies, coughing babies, things like that have the potential for being seen, and the wait for a sexual assault victim can be quite prolonged if you do not have a team that comes in and takes over the care. Okay? What I recommend in that case is always be willing to go and talk to the charge nurse. That is the person that can make things happen, and explain to them how long they've been waiting. If you have any reason that you can bump them up in what we call the acuity, or meaning how much they need help, I would present that information right then and there. And most charge nurses are going to be very amenable to assisting as much as they can within the scope of what other patients they have that they're trying to care for. But always start with the charge nurse. The other thing is then that they're usually, once they're done with triage, they're turned over to some sort of primary care provider. So it might be another nurse, it might be a tech, and then that person will also go in and say, what's going on, tell me if you hurt anywhere, are you bleeding anywhere. So now we've had the potential that if you do not have a team and you do not have protocols in place, the victim has now had to tell her story twice at this point. They'll do it again, and maybe even again. They're going to ask for a history of the assault, and we'll talk about documentation in just a bit. But they're going to ask what happened, and again, the degree that they ask, how they ask, what they're looking for varies wildly over who that provider is and what sort of